Welcome to today's webinar called Reducing Injury-Related Hospital Admissions Among Children and Adolescents ages 0 through 19, the role of the new Title V MCH Block Grant National Performance Measure on Injury. I'm Becca Hunt from the Children's Safety Network, and I'll be moderating today's session. Before I pass things over to our presenters, my colleague Rebecca Wilmer will provide a quick overview of today's technology.
Thanks, Becca. There are two options to hear today's audio. You can listen through your computer speakers or call into our phone line at 866-835-7973. If you're participating via phone, please mute your computer speakers to eliminate echo. Phone lines will be muted during the presentation to eliminate background noise. If you have a question or are having any technical problems, please type them into the Q&A box on the left and we'll attempt to assist you. You can submit your questions and comments at any time during the presentation in the Q&A box. After the presentation, we'll pause for the presenters to answer your questions. This meeting will be recorded and archived and sent out to all registrants after the session with a copy of the slides.
Thank you, Rebecca. The first presenter on today's webinar is Dr. Rebecca Spicer, Director of the Children's Safety Network's Economic and Data Analysis Resource Center at the Pacific Institute for Research and Evaluation. She has contributed to the field of injury control research for nearly 20 years, and her expertise includes evaluation, cost analysis, and study design. Dr. Spicer will set the stage for understanding the burden of injury-related hospitalizations in the U.S. before we discuss the National Performance Measure on reducing injury-related hospitalization admissions. Dr. Spicer?
Thanks, Becca, and everyone. Welcome to this Children's Safety Network webinar. Our Economic and Data Analysis Resource Center has a lot of experience in injury data analysis, including the hospitalization data that are the prime data source for the Injury National Performance Measure we'll be talking about today. And later in the webinar, my colleague Paul Jones will talk a bit about some of the resources that our center has created for the state. So since you're attending this webinar, these facts may already be familiar, but the burden of injury is that more children and adolescents ages 1 to 19 die from injuries and violence than all diseases combined. And every year, nearly 320,000 hospitalizations are due to injury to the 0 to 19-year-old age group. Here is CDC's table of the 10 leading causes of death. So for children and adolescents ages 1 to 19, unintentional injury, and that could be unintentional falls, cuts, gunshot wounds, unintentional gunshot wounds, motor vehicle crashes, bike injuries. Unintentional injury, here in blue, is the leading cause of death. For kids over 10, here, you can see this here, unintentional injuries, suicide and homicide, are important causes of death. And for those under 10, homicide is also an important cause of death, generally from child abuse and neglect. All right, so fatalities are the tip of the iceberg. In 2010, 13,819 kids aged 0 to 19 of an injury, either unintentional or intentional, and an estimated 310,500 injury-related hospitalizations and over 9 million injury-related emergency department visits occurred. There are another 12 million plus injuries treated in physician offices that are not included at the bottom of this pyramid. So not only is injury the leading cause of death, but for every fatality, 22 hospitalizations and 671 injury-related emergency department visits occur. This table from the CDC shows the leading causes of fatal injury. Among children under 1, the predominant, about 90%, cause of injury death is sudden unexplained infant death. Otherwise, injury fatality rates for other causes are fairly low in this age group relative to other age groups. In the elder age groups, motor vehicle crashes play an important role. And in those over 10, as we saw in the larger CDC table there just previously, intentional injuries, so suicide and homicide, are important causes of injury death. This table breaks out the mechanism involved in the intentional death, and you can see that guns and suffocation are the most common mechanisms. And so a table like this is useful to identify areas to intervene to reduce injury deaths. But the national performance measure that we are concerned with involves hospitalized injuries. So the CSN Data Center created the same table, but instead used the nationwide inpatient sample data set from the Agency for Healthcare Research and Quality, AHRQ. These are national estimates of hospitalizations based on 45 state hospital discharge data. And my colleague Paul will talk a bit about the analyses and resources we've created with the state-level data, hospitalization data from AHRQ later in the webinar. Hospitalized injuries are the most severe of the non-fatal injuries with serious consequences. They often result in school days missed and parents' loss of work to care for the injured child. And in the worst cases, these child injuries result in temporary or permanent disability that will affect the child for the rest of his or her life. So the table shows the leading causes of hospitalized injury in the United States. It looks very different from fatal injury table. Falls are the #1 cause of hospitalization for kids ages 0 to 14. And here too we see that intentional injuries are leading causes of injury hospitalizations in kids over 10, self-inflicted suicide attempts and assaults among teenagers. Motor vehicle crashes are important causes of injury hospitalizations among the kids as they move into booster seats and then start driving here and here. Therefore, in moving the needle on hospitalized injury rates, a state's focus may be different than if they were addressing fatal injuries. So again, using the AHRQ nationwide inpatient sample data, the hospitalization data, we analyzed the distribution of hospitalized injuries by age for 2010. Hospitalized injuries are highest in the first few years of life and in the teens. Recall that fatal injury rates in those under 1 are not as high as in other age groups, but hospitalizations tell a different story, and rates for kids under 1 are high relative to other ages. For those under 3, the higher numbers are generally due to the excess of unintentional injury, these are the red part of the bar, with falls being a leading cause. But in the older ages, 15 and over, the higher injury hospitalizations are primarily an excess of motor vehicle crashes in green and intentional injuries in purple. Medically treated injuries result in nearly $30 billion in medical costs and $77 billion in work loss costs. This excludes the cost of the 12 million plus injuries treated in physician offices. So medical costs include medical care, rehabilitation, long-term medical and institutional care, prescriptions, and coroner services in the case of fatality. Work loss costs include work loss in the value of wage and household work that a child won't be able to do if he or she is killed or permanently disabled, but it also includes wages and fringe benefits and household work that the parents are unable to do when caring for their child. Based on data from the 2008 Medical Expenditure Panel Survey of healthcare costs, 15.7% of all medical spending for kids ages 0 to 19 is due to injury. And we use costs as a measure of severity. More severe and debilitating injuries will result in higher costs. So work loss costs are a good measure of long-term consequences. This graph presents average cost per hospitalized injury for selected causes. Motor vehicle crashes have particularly high costs. I'm trying to get my cursor here. Here are motor vehicle injuries. They have particularly high costs, probably due to the large number of traumatic brain injuries, or TBIs, which are particularly debilitating. Injuries that result in disability like brain injuries and spine injuries have long-term consequences. This graph presents the percent of hospitalized injuries that are transferred to rehab facilities. Motor vehicle occupant injuries, this first bar, are both numerous and have a high percent with long-term consequences. Falls over here, on the other hand, are numerous, but on average are less debilitating. We know that injuries are preventable, and we have made great strides in reducing the burden of injury. This graph shows the progress we've made in the past decade, and if this graph included the 90s, the percent reductions would be even higher. But still, injury remains the leading cause of death. The advantage to us now in 2014 is the wealth of evidence-based programs that can be adapted to address different problems. Here's the progress we've made to prevent injuries to reduce motor vehicle fatality rates. The dramatic reductions among 15 to 19-year-olds, that green line there near the top, is due to graduated licensing programs in general, now universal across the U.S. And if we extend the graph back into the 90s, we'd see the dramatic reductions from increased car seat and booster seat use among these younger age groups down here below with the lower rates of injury. So here is more evidence of effective programs. These are emergency department visit data from the Consumer Product Safety Commission. Take a look at the drop in the rankings for stairs between 1995 and 2009. We know that much of this is due to baby walker recalls and legislation, but there are new issues that arise. Look at the increased role of sports among kids ages 10 to 19. Effective programs can also be cost beneficial. When making decisions with limited resources, this is important to consider, and often decision makers listen to numbers, to dollars. The Children's Safety Network Data Center has analyzed the costs and benefits of 168 interventions. Here's a sample. These are presented and discussed in our resource, Injury Prevention, What Works. It's available on our website, and there are many other great resources for states on the CSN website. My colleague Paul will present some of them later in the webinar, but I encourage you to also explore the website on your own. And feel free to contact me if you have questions or special requests. That's my contact information. So thank you.
Thank you, Dr. Spicer. We'd like to hold questions until the end. If you have a question, please enter it into the chat box on the left, and we'll respond as time allows at the end of the webinar. Next, Dr. Ashley Hurai, a health scientist at the U.S. Department of Health and Human Services, Health Resources and Services Administration, Maternal and Child Health Bureau, Office of Epidemiology and Research, will introduce the new Title V MCH Block Grant National Performance Measure number 7 on injury-related hospitalization. In her role at the Maternal and Child Health Bureau, Dr. Hurai oversees an annual MCH epidemiology training course, produces the Women's Health USA data book, and conducts an analysis to inform and evaluate Bureau initiatives, including the block grant transformation and the infant mortality coin. Ashley?
Thanks, Becca. So just for some background on the Title V program for any of those who might not be familiar, it was enacted as part of the Title V of the Social Security Act in 1935, a categorical program that was converted to a formula-based block grant to states in 1981. It is the largest source of public health funding for maternal and child health broadly, including women, infants, children and youth with special health care needs and their families. It's a federal-state partnership where at least 3 of 4 federal dollars must be matched by the states and ends up resulting in nearly $6 billion in funding for state and local MCH programs annually. In 2013, Title V served nearly 42 million pregnant women, infants, children, and CSHCN through screening and preventive services, enabling services, informational hotlines, and direct care and treatment. The 59 states, territories, and jurisdictions must apply for funding annually and conduct a needs assessment every 5 years to identify state priorities to address and focus their work. Under our Bureau Administrator's leadership, Dr. Michael Liu, we've undergone a recent major transformation of the block grant guidance, which will be implemented this year. So there was a triple aim for this transformation. First, to reduce burden. We streamlined the annual report and application, reducing the number of forms, reducing the length of a needs assessment summary that's directly integrated into the application, reducing data reporting by pre-populating from federal sources. And secondly, to maintain flexibility, we really wanted states to have a choice in the measures that they chose to work on over the 5-year cycle. So they will choose 8 of 15 national performance measures across 6 population domains and continue to select state-specific performance measures, 3 to 5 of those, and now newly develop evidence-based informed strategy measures that really tap the activities and programs that the state is undertaking to address these performance measures. And so this new performance measure framework really will improve accountability and document the impact that Title V is having. We have fewer performance measures that are really directly tied to Title V activities, and a new framework that I'll introduce to help track performance in relation to those activities that are captured in your evidence-based informed strategy measures. And finally, we'll have a revamped Title V information system to accompany this new performance measure framework. So here is the new 3-tiered performance measure framework, and at the center are the national performance measures, which reflect short and medium-term outcomes, mostly health status indicators, behaviors, and access to quality health care. And these were selected because they were considered modifiable by Title V activities that are captured in those evidence-based informed strategy measures. And these are measures that states have an interest and resources dedicated to addressing those performance measures that have large impact or costs associated with them, and that have room for improvement or disparities that may need to be addressed. And we really hope to better tell the story of the Title V impact by quantifying those activities and strategies in relation to performance, and then ultimately those long-term outcomes like morbidity and mortality. And this new framework will have the flexibility to perform iterative cycles, trying new activities and strategies, and modifying and retiring evidence-based strategy measures that may not have its intended impact in Plan, Do, Study, Act cycles. So the new performance measures are organized across 6 population domains to address the full spectrum of women, infant, child, adolescent, CSHCN, and cross-cutting or life course measures. And states must select 8 of 15 national performance measures across these 6 domains, and at least 1 measure per domain. So for the child health measures, there are 3 that states can select among. Injury is the leading cause of morbidity and mortality, as Dr. Spicer just showed, in children and adolescents, and of course it needed to be represented as a performance measure, and it is the new National Performance Measure number 7, non-fatal injury-related hospital admissions per 100,000 children, ages 0 to 9. And it is coming from the state inpatient databases maintained by AHRQ. The other measures that may be selected are developmental screening and physical activity for young children. Moving into adolescent health, we again have injury hospitalization tracked for those ages 10 to 19, and physical activity is also a measure that can be selected for adolescents. The 2 other adolescent measures, bullying and adolescent well visit, can also relate to injury. Bullying can lead to violent injury, and screening and counseling for injury risks like motor vehicle safety, depression, or bullying can occur in the adolescent well visit. So here are the details on the new National Performance Measure number 7, the goal of reducing hospital admissions for non-fatal injury among children ages 0 to 9 and 10 to 19 years. And we have that numerator, the number of hospital admissions among children with a primary diagnosis of unintentional or intentional injury. And that does exclude those in-hospital deaths and follows a healthy people indicator definition as well. And again, that data source is coming from the Agency for Healthcare Research and Quality, the state inpatient databases that are capturing hospital discharge data at the state level. And what we will provide as part of the new information system will be the overall state data by year for trending and to help with objective setting. And we'll also provide the data by various demographic stratifiers in each state for the current year. And this will help states better target interventions in knowing who is most at risk and where disparities lie. The Children's Safety Network will also be a tremendous resource to be able to look at injury hospitalization by mechanism and intent to help identify strategies that address those leading causes of injury in a given age group and state. In the new framework, here again, we have the evidence-based informed strategy measures, which should lead to improvements in performance, in this case, the National Performance Measure number 7, injury hospitalization, which in turn should yield improvements in related national outcome measures, like child mortality, adolescent mortality, motor vehicle mortality, and adolescent suicide. And we don't expect a linear one-to-one relationship. As Dr. Spicer previously presented, some of the leading causes of non-fatal injury are not the causes of fatal injury, and vice versa. The accountability in this framework is mostly on the performance measure itself, and it is really an extra advantage to influence those ultimate outcomes. And we will hear from subsequent presenters around the activities and strategies that can be quantified as those evidence-based informed strategy measures. And really the main guidelines are just that they are quantifiable and they can really be selected across the range of the 10 essential public health services, including assessment, for example, child death review activities and translation to prevention strategies, policy development, and program development like educational campaigns or policies, and assurance, and including enforcement of existing laws and links to care and a properly trained workforce. So what's the timeline for the rollout of these new measures? The new National Performance Measure and outcome measures that we will pre-populate will be viewable in the new TVIS data entry system, the electronic handbooks, the grant management system in April. And we're hoping to have as many measures viewable by then as possible. 3.5 months later, in mid-July, the state fiscal year 2016 applications are due with a needs assessment and a selection of the 8 of 15 new national performance measures. The public-facing Title V information system will launch in January of 2016, and this is where we hope to have improved functionality for graphics and tracking of the national performance measures in relation to the evidence-based strategy measures and the national outcome measures in relation to those national performance measures. Finally, in the FY17 application for funds due in July of next year, 2016, the evidence-based strategy measures and 3 to 5 state performance measures are due. And that we're really phasing in this new system and allowing time for developing those evidence-based informed strategy measures, which should roughly follow the state action plans that are due this year in July. And finally, I just want to show some resources available to find out more information about the Title V block grant transformation. You can visit the Bureau's block grant webpage. We are providing lots of assistance in developing these new evidence-based informed strategy measures. We're funding a resource center that's compiling these evidence-based practices along the 15 national performance measures. and you can see those evidence briefs there at the MCH Library at Georgetown. And there's also a lot of topic-specific resources like the Children's Safety Network to provide assistance in selecting and working towards injury and violence prevention objectives. And we'll hear more about CSN and other efforts that can assist states in this work in subsequent presentations. Thank you.
Thank you so much, Dr. Hurai. That was a really informative presentation. Erin Rainey, the Director of Injury and Violence Prevention at the Health Resources and Services Administration Maternal and Child Health Bureau, will now provide a brief overview of resources available to states who select National Performance Measure number 7. At MCHB, Ms. Rainey leads HRSA's bullying prevention efforts and serves as project officer for the Children's Safety Network and the National Action Partnership to Promote Safe Sleep. Erin?
Thanks so much, Becca. Good afternoon, everyone. I'm really happy to join you and talk briefly about some resources that are designed to support those states that ultimately end up selecting the national performance measure we're talking about today, number 7, injury-related hospitalization. The primary venue, primary mechanism for providing that support will continue to be through the Children's Safety Network program. If you are with us today on the webinar, you're no stranger to CSN. Something you may not have known is that HRSA created the Children's Safety Network program back in 1991. And what has remained to this day is its core function to really catalyze the translation of injury prevention research to practice, and working primarily in terms of a target audience with state health departments and supporting them in their work. So right now, the Children's Safety Network program is in its year 3 of 3 of a funding cycle, and a new 3-year project period will launch on July 1. So what I'm able to share with you today is a little bit of the transformation of the Children's Safety Network that has been advanced to sort of match and support the transformation of the MCH block grant that Dr. Hurai just explained to you. So through this next project period, there will be 3 components of activities through the Children's Safety Network. 1, a national coordinated child safety initiative, which is really designed to establish and drive forward a national cohesive vision around how to keep kids safe. Second is a Child Safety Collaborative Innovation and Improvement Network, a COIN, and I'll talk about that more in a minute. And then the third component is child safety promotion capacity building, which really means centers on that subject matter expertise of supporting state health departments and others who want to learn about what are the best practices in injury prevention. So moving forward to explain what is a COIN. A COIN is a state-to-state network. It's an infrastructure that can support driving forward across state lines on issues of priority. So there are 4 key elements. There are coordinated strategies that are identified across state lines. There is some structured collaborative learning to infuse that evidence-based, that subject matter expertise into decision-making around priority strategies. There are common benchmarks. So working together, again, across state lines to identify metrics of success that everyone can be moving toward. And the method of using rapid test cycles and bringing in the concept of quality improvement. Those of you on the line may have been familiar with the HRSA-supported infant mortality COIN, which launched in July of 2012, and work with that COIN continues to this day. This is a model that is similar based on that concept, which I want to very quickly visually show you. The idea here is that the COIN is a support network for those states who ultimately choose this national performance measure. Also invited to this coin would be those who select the national performance measures on safe infant sleep and bullying prevention. And how this would kick off across about a year to a year and a half lifespan is those states would convene their state leadership across different sectors into a summit around child safety. Together, you'd look at data, you'd look at the evidence base, you would take stock of the resources you have in hand on the case-by-case basis across states, and would select topic areas that to create ultimately strategy teams. And that's where we get to this across state lines partnership and collaboration. Once those strategy teams form, they would begin to develop some test packages, change packages to advance small changes at first that scale up to large changes to make measurable impact in child safety. And all across this whole span, that National Coordinated Child Safety Initiative I spoke of would be providing additional support and resources to this effort to guide the process. So just to sort of get this in a more tangible place, what might a COIN team be working on? Let's say that there is a COIN strategy team that chooses bullying prevention as a focus. A potential improvement could be to increase the frequency that pediatricians screen for bullying during a visit. And this would be in alignment with the Bright Futures Health Supervision Guidelines. So how might you go about measuring that? You could start with the proportion of providers that receive bullying screening training and tools through the maybe partnership with an AAP state chapter. You could look at the proportion of pediatric practices who agree to integrate bullying screening as a standard of practice. You could look at the number of youth at risk identified through that screening who were ultimately connected to support. Let's look at one more example. What if the strategy team selected motor vehicle crash injuries? Potential improvement here could be increasing the proportion of families who are served through WIC programs, which use properly installed and height weight appropriate child safety seats. So if that were your strategy, how might you measure it? You could look at increasing knowledge, first of all, among WIC program leadership on the specific risk of motor vehicle crash injuries to their client population. That's sort of the collaborative building of the bridge. You could move on to saying, let's look at the increased proportion of local child safety seat programs that have an MOU with their local WIC providers so that they would be there to support WIC clients who need this resource. Finally, maybe you would look at increasing the proportion of families who are ultimately screened and then subsequently referred for those child safety seat installation supports. So again, a quick visual. This COIN is, again, designed more than anything to support, to wrap around and help states who choose these child safety related national performance measures, would support bringing state leadership together to do some strategic planning around this. And I'm going to quickly show you this visual. So you'd have come together at the summit. You would select priority areas and move through that across-state process to identify priorities, identify metrics, and come back to the table on a regular basis for that collaborative learning and to share progress made. So thank you for the chance to share a little bit of that with you, of what's coming next for the great work of Children's Safety Network. And with that, I'll pass it back over. Thank you.
Thank you so much, Erin. It was great to hear about the upcoming COIN. To further explore resources available to states who select National Performance Measure number 7, I'd like to introduce Dr. Paul Jones. Dr. Jones is an Associate Research Scientist at the Children's Safety Network Economic and Data Resource Center at the Pacific Institute for Research and Evaluation. Dr. Jones regularly examines the Agency for Healthcare Research Quality, AHRQ's, state hospital discharge databases to estimate the burden of childhood injury and will discuss the Children's Safety Network's state hospitalization fact sheets. Paul?
Hi, everyone, and thanks for that wonderful introduction, Becca. I really appreciate it. My name is Paul Jones, and I'm an Associate Research Scientist at PIRE. I'm also an analyst for CSN EDARC. In this portion of today's webinar, I'll provide an overview of our state hospitalization fact sheets. So with no further ado, let's begin. As many of you know, CSN has many popular resources that are intended to help people better understand, predict, and control youth injury. These resources include fact sheets, blog posts, maps, and a host of other useful tools. My colleague, Becca Hunt, will discuss many of these resources later in the webinar. Nonetheless, I want to draw your attention to what I believe is one of our hidden gems, the CSN State Hospitalization Fact Sheets. The Maryland sheet is shown here. Earlier, Dr. Spicer discussed the injury prevention pyramid as a way to understand the burden of fatal and non-fatal injuries. A key take-home point, however, is that merely focusing on one level of the pyramid, such as fatalities, can provide an incomplete picture of the injury burden. To illustrate this point, consider the incidence and rates associated with suicide-related fatalities among teens between the ages of 15 and 19. As shown here in Figure 1, suicides were more common among men than among women in 2003. However, as seen here in Figure 2, when we look at non-fatal self-inflicted attempts in 2003, we notice that the epidemiology shifts as a function of gender. Women engaged in a higher number of attempts than men did. Though not presented here, the rates associated with these injuries tell a similar story. The mechanisms associated with these injuries also differ. For instance, suicides often involve firearms, whereas non-fatal self-inflicted attempts often involve poisonings or cuts and/or piercings. In short, understanding youth injury through the lens of hospital discharge data can serve as an important complement to mortality data. Indeed, our fact sheets can help you to better understand the burden of youth injury in your state. They can also inform your injury prevention programming. Moreover, you can use these fact sheets to address the Injury Hospitalization National Performance Measure. Now, I'd be remiss if I didn't mention that our hospitalization fact sheets also coincide with the CSN leading causes of hospital-admitted injuries tables that are shown here. The Maryland table is shown here, and I'm sure that many of you may already be familiar with this resource. Because accessing these fact sheets was a learning objective of this talk, and doing so can help you learn more about injury-related hospitalizations in your state, I'll explain how you can locate these tables on the CSN website. You can start by going to the CSN homepage at www.childrensafetynetwork.org and clicking on the State Information tab, as I've done here in this example. Next, you'll be taken to a U.S. map with each state in Washington, D.C. listed on the page. At this point, simply click on the state that you're interested in. Since I reside in Maryland, I'll click on the link for Maryland, and I've depicted that here in this graphic. Next, you'll be taken to a page with a lot of resources, including state contacts, our fact sheets, our state fact sheets, which contain the top 5 hospitalization tables that I mentioned earlier, state highlights, useful news articles, and finally, at the bottom of the page, you'll find the key link. Look under the header, State-Specific Reports and Data, and click on the tab devoted to your state. And voila, the link will bring you directly to the state table that you've selected, which was Maryland in my case. Now I'd like to briefly discuss the data source for our hospitalization tables. I'll also cover some of the useful features contained within these sheets. Okay, so all the data in our hospital tables are based on incidence counts taken from the Healthcare Costs and Utilization Projects, or HCUPs, state inpatient databases, which are also known as the SID. These data are maintained by the Agency for Healthcare Research and Quality, or AHRQ, and in 2011, there were 45 states that provided HCUP SID data. These states are depicted in purple on this map. Now, states not providing data are shown in white. So as you can see, many of the states that would potentially use these data are covered. So there are only a few that aren't covered with respect to HCUP-SID data. Indeed, there are several noteworthy features associated with this fact sheet series. For instance, our sheets provide incidence counts and rates associated with injury hospitalizations. And as many of you know, rates allow for these data to be converted into a common metric that facilitates cross-state comparisons. We also break out our incident counts and rates by age group, intent, and mechanism. Though there are many uses for our hospitalization fact sheets, one way to use this resource is to examine the overall rates of youth injury hospitalizations across states. Now, in this practical example, I present a map showing the percentage change in non-fatal hospitalized injury rates by state among youth aged 0 to 19. My comparison is between 2003 rates and 2011 rates, and I've also broken out these data into quartiles. Now, states that have experienced the highest percentage change over this period, namely the greatest reduction in their non-fatal hospitalized injury rate, appear in dark green. Those with the lowest percentage change appear in light green. States that are missing 1 or more years of data or that we're unable to report on are depicted in white. Now, although it's difficult to determine what caused these descriptive findings, for instance, improved e-coding, greater healthcare access and quality, other social and environmental variables, and/or some combination of these factors, I want to emphasize that state maps such as this one can easily be made using our fact sheets. Because no study is without limitations, there are several notable exclusions and shortcomings associated with our sheets. In terms of exclusions, we remove cases from our analysis including fatalities, medical misadventures, transfers in from another hospital or long-term care facility, and readmissions for our own purposes. But we also withhold case counts between 1 and 10 from our tables, which is part of our data use agreement with AHRQ. And all of these exclusions are listed in the notes section of each state table. In terms of limitations, not all states provide SID data. Some states were also reluctant to allow us to use their data in the past. But you should be aware that there is also a data lag associated with the SID. Now, I have this on good authority that 2013 is the most recent year of SID data available, that 2014 SID data is expected in January 2016, and generally, there's about a 15 to 20-month lag between the current year and the most recent year of SID data available. So in summary, hospital discharge data are an important complement to mortality data. In addition, our fact sheets allow you to easily create maps, and they can help you in making cross-state comparisons. Now, I also want to point out a couple of things to look for from CSN on the horizon in terms of our fact sheets. So our 2011 fact sheets will be disseminated in early 2015, and we are currently working on our 2012 fact sheets, which we expect to be out in late 2015. In addition, CSN EDARC offers free technical assistance for those that may be interested. So in closing, here's my contact information for those of you who would like to send me a line. Email generally works best for me, but I can be reached by phone or snail mail as well. So thanks again for tuning into my presentation, and I hope that this information is helpful in your future injury prevention efforts.
Great, thank you so much, Paul. That was a really interesting and informative presentation. In just a few minutes, I'll be providing the last presentation of the day. So in the meantime, I'd like to remind you to enter any questions you have into the Q&A box on the left-hand side of the screen, and we'll be getting to them in just a few more minutes. So I'm going to quickly review some additional resources for identifying effective strategies of injury prevention available through the Children's Safety Network website. I'm a Training and Technical Assistance Associate with CSN, where I work with states on collecting data, designing and implementing programs on topics ranging from distracted and impaired driving prevention to traumatic brain injury and firearm safety. CSN believes that effective injury prevention strategies follow the public health model, which I'm sure you all know like the back of your hand. I'm not going to review the model, but rather talk about the CSN resources information available to you that can help you follow and implement the model. You've already heard from Paul about the state-specific information on hospitalization, which can help you identify and monitor the problem and identify risk factors related to age. So I'm going to focus on identifying other risk factors, developing and testing prevention strategies, and assuring widespread adoption. With access to more than 4,000 injury and violence prevention publications and databases, CSN can provide you with support analyzing data to identify risk factors, make the case for why you should focus on injury prevention, including cost savings and data presentations, and monitor how injury is changing, hopefully because of the hard work that you're doing. CSN can also provide guidance in program management and planning, or help identify funding sources, build partnerships, and identify what other states are doing that's working for them and might work for you too. Perhaps most relevant for this presentation, CSN can help you identify known best practices and research on emerging issues. CSN, in addition to the one-on-one technical assistance to the states that we provide, can provide a number of resources through the website. The next few slides will highlight some of those resources. CSN keeps an ever-expanding list of injury prevention pages. These pages cover the leading intentional and unintentional injuries across the country. The information on this slide is live links, so you can visit any of these pages. Each page contains a definition of the issue, information about the magnitude or burden of the issue, and resources that are available on the CSN website and from our external partners that will be helpful in understanding and addressing the problem. This is a screenshot of one of the injury topic pages. As you can see, it also has a section referring to known prevention strategies. These sample strategies are often individual level strategies, that is, individual level referring to the socio-ecological model, which separates intervention into individual, relationship, community, and societal interventions. But CSN can help you identify effective societal and community level interventions that help put these individual level strategies in place. For example, working with landlord and tenant associations to put window guard policies in place, training home visitors on identifying fall and tripping hazards so they can work with their clients on removing or mitigating those hazards, or communicating with families about the importance of properly installing and using safety devices like window guards, stair guards, furniture straps, helmets, and more. The website also contains various topic-specific fact sheets, infographics, and resource guides which can help you frame the problem, learn more about it, and learn what others have done to address it. You can access these resources through the injury prevention pages I just mentioned, or by following the links on the screen. The resources listed on this slide are just a few examples of the most recent resources we have developed. CSN also offers live webinars, just like the one you're on today, which are typically recorded and archived on our website for free viewing at your leisure. These webinars typically occur as part of a series, such as the series on preventing prescription medication abuse, or a community of practice, which requires an application, or as once-off events, such as today's webinar, or a previous webinar covering the issue of e-cigarette poisoning among youth and children. You can access all the publicly available webinars by visiting www.childrensafetynetwork.org/webinars. Finally, CSN also offers a wide variety of publications which can help you identify and implement effective strategies. I've pulled out a few publications which you might find most relevant. All of these publications were updated in 2014. The first one is a compendium of known injury prevention strategies organized by injury topic, which explains the cost of implementing the intervention and how much you can expect to save your state if it is implemented. My colleague Becky Spicer mentioned that at the beginning of the presentation. The second two are specifically geared towards MCH and IVP directors working on their needs assessment for the Maternal and Child Health Block Grant. They explain why and how injury should be included in your needs assessment. And of course, CSN is here to answer any questions, big or small, that you might have about collecting, analyzing, and reporting data, intervention design and implementation, specific injury topics, including burden, risk, and protective factors, and what other states are doing to reduce the burden of unintentional and intentional injuries in the maternal and child health population. States are busy, so I hope this provides clarification and sparks some ideas for how to start identifying intervention strategies that can work in your state. We're now going to move into a question and answer session. So I hope that you have had a chance to submit your questions into the Q&A box on the left-hand side of the screen. I'll read those out loud for our presenters for them to respond to. So I know one of the first questions that came in regarding the TVIS system, so this is a question for Erin and Dr. Harai, is whether or not data for hospitalization will be pre-populated into the system for those who have selected the performance measure as well as those who have not selected the performance measure, or if it will be entered for everyone.
Great question. It actually will be populated for all states with available data. So we can really show the full national picture of these measures and really be able to correlate the success of strategies and having a control group of states that did not select work towards addressing a given performance measure.
Thank you, Ashley. Now I'm wondering if Dr. Spicer can give us a definition of intentional injury versus unintentional injury.
Yep, that's a good question for those who are new to the injury field. So unintentional injuries are, and I'm going to use the A word, essentially thought of as accidental injuries. We don't like the A word in this field because it kind of connotates random events. When we know that injuries from science, we know that injuries are predictable and preventable. So those are those unintentional injuries. Falls, running into something, falling off your bike, things like that. Intentional injuries are those where the intent is to hurt yourself or to hurt someone else. So it's suicide attempts or suicide and assaults and homicides.
Great. Thank you so much, Becky. I really appreciate it. The next question I think will go to both Dr. Harai and Dr. Spicer. It's about e-coding. One of the first slides showed the increase in sports-related injuries, and one of our participants is wondering if e-coding for sports is relatively new and if that impacts the way that data is displayed. I think this is very important for thinking about reporting and showing impact in the future in changes between ICD-9 and 10 and how the way that you capture your data might impact the way that it is represented. Do you have any comments or thoughts on that?
Yeah, actually, I'll take this first, Ashley. Joanne, I think you were asked that question when you saw the slide where I showed the change as a leading cause of stair injuries and kind of how sports are becoming a bigger issue now. Those data are not coded with ICD-9 or ICD-10 for that matter. Those are data from the Consumer Product Safety Commission, National Electronic Injury Surveillance System. They are emergency department visits for injury, and they're coded by product or activity involved in the injury. It's a really great data set because it allows you to look at injuries in a way different from the ICD-coded data, which if the ICD-9 coded, you can't get a handle on sports or even stairs either. There's no good coding for stairs and steps in the ICD coding. But these nice data are great. Now, it's a little unfair for me to have shown that slide. It's at the end, Becca. It's this one. Because they can't be analyzed by state. They're national estimates. The next answer to that question is, you're right, ICD-9 data, you just can't get a handle on sports. And at the moment, the hospitalization data at AHRQ are ICD-9 coded. But in the next couple of years, they're going to be moving on to ICD-10, where there's a better coding system for sports. Ashley, do you want to add anything to that?
No, you're really the injury expert here, and CSN is really the resource to provide that greater detail on mechanism and intent. But fascinating work there.
Oh, thanks.
Thank you, Dr. Spicer. I'm going to send the next question over to Erin. The question is, how does this dovetail with CDC injury prevention initiatives' existing plans?
Great, thank you. I'm so happy to see this question. I have a good answer for it. Within our vision and our sort of the background behind this next step with establishing a child safety coin and this national coordinated child safety initiative, we are pointing directly to 3 foundational frameworks to build upon. One of them being the National Action Plan for Child Injury Prevention that was led by development through the CDC in partnership with 80+ organizations out there, including HRSA, as well as certainly the Title V, the MCH National Performance Measures, and Healthy People 2020. So the Healthy People 2020 objective that intersects with child safety, we also see this as being responsive to and integrated with that. So for example, that the National Action Plan that you're mentioning has about, I'm looking here, about maybe 12 or 15 specific recommendations around HRSA systems that could be advanced through this coin and through the Children's Safety Network, through the work of the block grants. So I'm just going to say a couple of examples. One recommendation from the National Action Plan is to support the inclusion of child injury risk assessment within home visiting programs. That's the kind of thing that could be advanced through this coin. Another one, increased universal access to poison control centers, comprehensive trauma care systems, pre-hospital and preventive services. That's another kind of thing that could be advanced. So we're working hard to make sure that we are walking arm in arm with our federal partners through this. And the last thing that we want to do is step away from the opportunities we have right now to be synergistic. So thank you for that question.
Great, thank you. Another question we have about this performance measure is it necessary to cover all 6 domains for this performance measure?
I believe the question is referring to the 6 population domains, and so no, this performance measure is really only applying to the child and adolescent domains. So it can be selected for either children, adolescents, or both. We separated it into those 2 populations because we know that the causes of injury are very different for young children versus adolescents, and so the strategies would need to be very different to address them. So it really is targeting just those 2 groups, children and adolescents.
Thank you. I have 2 data-specific questions regarding the causes of injuries. One is, are ATV-related injuries counted as motor vehicle injuries or something else? And the other is about falls that happen in the sleep environment, and if there's any data on falls that happen in the sleep environment.
Okay, Judy asked about falls in the sleep environment. And, okay, the short answer is no, we can't get to that data easily because we don't know what they were doing when they fell. However, and I don't want to go on a long tirade, a long description about this, but we did some fun work with the NICE data. Remember, these are these national estimates of emergency department visits, and you can look at them by the product or the activity involved. So we can look at bed-related injuries. There is also, however, some descriptor of the type of, let's see, of the cause of the more of an E-code kind of descriptor like falls. and we could possibly look at falls from beds or falls from cribs. We could possibly do that, and if you want to pursue that, send me an email. But the short answer is no, that is not easily done with the data that are available. I might be able to finagle something, though. And then the question about ATVs. No, those are not going to be in the National Highway Traffic Safety Administration's motor vehicle traffic-related injuries because generally they happen off highways and roads, so they're going to be off-road. And those are coded a little bit differently in the data. You can get to those data, but all the motor vehicle traffic data that I presented today don't include ATVs. But you can look at ATVs on their own by identifying vehicle type involved and vehicle type involved. There's a code for ATVs, yes.
Great, thank you, Becky. The next question is, do you recommend estimating performance indicator number 7 using diagnosis variables or e-cause variables or a combination of both?
Okay, that's a good question. So what you're asking is diagnosis variables are the things like nature of injury, a broken arm, a contusion, etc., and body type injured, the head, the arm, etc. Those are the diagnosis variables. The E-codes are the cause. And so every injury in the hospitalization data has both. They'll have at least one E-code. Many states have more than one. And also primary diagnoses. So you can look at both. What would I recommend? It really depends on what you want to look at. States that are going to try to address traumatic brain injuries are going to use the diagnosis codes. But you know what? They're going to want to inform their efforts using the cause code. So you'll probably want to use both.
Great, thanks so much. All right, we only have one more question in the queue, which means we might wrap up this webinar a little bit early today. But that last question is certainly a doozy. It's, if you could do one thing to lower childhood injury deaths or hospitalizations, what would you do or recommend at a state public health leader to do?
Becca, this is Erin, and I'll tackle this one first. First of all, love the question, love the vision behind that. Wish I had an obvious magical answer, because if I had that, I have a feeling we would be able to advance that and solve this problem of child injury. However, I will say from my perspective, I think the power in answering that question lies as you get closer to the local communities. And I think that's where states have quite a bit of power to touch data and to really dive deep to understand. I mean, there's quite a bit of diversity across the country in terms of injury landscape. And I think that that is also part of the strength of this COIN approach that we talked about, which is to, again, bring folks to the table, pushing them to look deeper and to understand truly what the data is calling for their particular state or region or priority communities within their state. And then you go and you marry that analysis with the best of what we can find and what we can touch in terms of evidence-based, evidence-informed strategies for prevention. So it's that marriage that I think ultimately will get us there.
Great, thank you so much, Erin. I couldn't agree more. I really believe that addressing childhood injury, deaths, and hospitalizations requires strong partnerships, lots of evidence, lots of research, and collective action that is holistic and comprehensive. So thanks for touching on that. We don't have any more questions in the queue now, and I believe that we've covered a lot of ground today. So I'd like to close things out. I'd like to remind you that there is a brief evaluation on the link on the screen in front of you. If you wouldn't mind filling that out, we're always looking to improve our work. And if you have any questions about the performance measure or about the resources at CSN or wrapping your head further around injury, hospitalization, and death rates, please don't hesitate to contact us. My email is rhunt@edc.org, and we'd be happy to answer any questions. Until next time, take care and stay safe.